Hmm? Hmm. Joint and others. And my dear friends, first of all, thank you for the opportunity to speak in front of this audience. I would be talking about osteoarthritis knee, but before that, I represent Atreya Hospital, the cute little baby hospital of Thrissur. So it becomes my duty to introduce the Department of Orthopedic Surgery through a couple of slides. So there are two of us who are full-timers and we have two others who are part-time orthopedic surgeons there. Now what is exclusive about Atreya Orthopedics Department is we do trauma, but apart from that, we do reconstructive orthopedic surgery. And this is the second center in the whole of Kerala, which is exclusive for the reconstructive orthopedic surgical work. So we are now 18 months after starting the department and we have started to walk. Mainly we deal with deformity correction and Illusory surgeries, and our team was the first to introduce computer assisted deformity correction surgery in South India long back in 2010. And now we use the state of the art equipments in this particular field at Atreya. So we primarily deal with limb deformities, both adult and pediatric, limb length discrepancies, complex trauma, bone loss and reconstruction of bone defects, post-trauma sequelae, mainly deformity, non-union and delayed union, and osteoarthritis. So we'll start off with a questionnaire. The number of audience is very less, so we can just do an interactive thing first. How many of you own a vehicle? Just raise your hands. Almost all of you. Now, how frequently do you check the wheel alignment? Yeah, so you are very meticulous about that. Now, how many of you have knee pain? At least once in a while. I see a few hands. And how many of you have knee replaced? 0. So we asked the same question during an Indian Orthopedic Association conference where there was an audience of somewhere around 1,500 people, and we saw only a couple of people who had their knee replaced. But the knee replacement is being done very frequently in each and every hospital. So have you at some point of time checked the alignment of your limb? Yes or no? You are very meticulous in checking the alignment of your car. Every 4,000 kilometers you check. But your lower limb alignment, has anybody checked? No. And how do you check? Go back to your room, remove your pants, stand in front of a long mirror and see whether your limb is straight or not. It's as simple as that. But we didn't bother to check it till date. Why? Because this was never included even in orthopedic curriculum, still in the orthopedic curriculum. So I'll come to the topic, osteoarthritis knee, conserve, realign or replace. And my focus will be on this realignment part. Why osteoarthritis? Because it's the most common cause of disability in the world, most common cause of pain and deformity, and the trends are always towards extremes of treatment. Either it is conservative or you go for a replacement. So patients usually come with joint pain, stiffness, swelling, crepitus, reduced range of movement, pain on active movement and extremes of movement, and there will be recurrent episodes of exacerbations. Most of us at some point of time either have felt this or are going to feel this. So how will you investigate? You need standing x-rays because that will show the clear picture. Lying down x-rays never give you the exact picture of an osteoarthritic knee. And you need a lateral in full extension to see whether your knee is gradually going into a flexion deformity. And standing x-rays, standing full length x-rays, that is only when you plan for a surgery, and MRI you do in selected situations. So people usually ask, can I walk? Can I climb stairs? I have recurrent buckling, recurrent swellings. Is medical therapy enough, or do you want to go for surgical intervention? Now, are we justified in asking a patient who is 50 years old to restrict their activities? I don't think so. At 50, you are active, going around, so no point in restricting your activities, and you're asking them to reduce weight. And with knee pain, it's very difficult to reduce the weight. So what are the risk factors? It has been proved by adequate number of studies that the most important risk factor is the alignment of your lower limb. Either you are having a bow leg or a knock knee. These are the two most important risk factors as far as an osteoarthritis, onset of osteoarthritis is concerned. Other associated things are fractures, ligament and meniscal injuries, developmental defects, infection and inflammation. In short, anything which affects the lower limb, let it be a trauma, let it be an infection, all these are finally going to end up as an osteoarthritis knee. So this is what alignment means. When you take a full length x-ray or when you stand, the body weight is directly transmitted from hip to the ground. It goes in a straight line. So if a limb is bent, say like you have a knock knee like this, I mean a bow leg like this, the body weight goes directly like this and your leg is or your lower limb is bent. So the entire load is being passed through the medial compartment of the knee and the lateral compartment is relatively not bearing any sort of weight. What happens? That area degenerates, the varus keeps on increasing, the deformity keeps on increasing, and the osteoarthritis also keeps on increasing. So what are the treatment options? Conservative, realignment, and replacement. When do you go for conservative treatment? It's early disease, when you have minimal symptoms, the pain has just started, minimal cartilage damage on X-ray, and a reasonably preserved joint space. You give a short course of NSAIDs, but the mainstay of treatment is always physiotherapy. Two important things. One is strengthen your quadriceps, and the second is strengthen your hip abductors and extensors. This is some part which is usually missed. You need to strengthen not only the knee, but also the hip abductors and extensors. Realignment. This would be the major part of my talk. I'm not going to take much time. Varus or bow legs, it's the most common thing. Valgus or a knock knee is less common in adults. Realignment means surgical correction of these deformities, and this is basically by cutting the bone or producing surgically creating a fracture, or which is otherwise called an osteotomy. So that's how you realign. You see a patient with an axis passing medial to the knee joint. You cut the tibia, 50% of the tibia, straighten it out, and you can see that the weight bearing axis is passing through almost the center or slightly lateral to the center of the knee. This is the opposite, knock knees. And this is after correction, the axis passing through the center of the knee. So this is what you basically do in realignment. You correct the bend at the right time so that patient has a pain-free knee with a complete range of movement. Now this is an underutilized option. It gives painless functional knee, preserves the cartilage and the knee, and prevents or prolong a future total knee replacement. Then why is it underutilized? One reason I mentioned earlier, it's not being covered in your medical school curriculum. Second thing is the replacement is a multinational company controlled business. So a lot of publicity is being given to that. So people, I'm not against replacement. In selected cases, I do replacement, but only when it is absolutely indicated, because replacement has its own complications. And once you develop a complication after replacement, your life is going to be a misery. So cartilage regenerate, do cartilage regenerate? Yes, it regenerates. This is proved by arthroscopic studies. Only thing is hyaline cartilage is replaced by a high quality fibrocartilage. So when do you realignment? When the symptoms is only confined to a single compartment of the knee. We all know that knee has three compartments, a medial one, a lateral one, and a patellofemoral one. So when it is confined to a single compartment or a single compartment plus a patellofemoral compartment symptom, you can go for a realignment procedure once the conservative treatment fails and the activities of daily living are affected. Relatively young patients, selective cases after 60 years. My youngest patient where I've done realignment is 19 years and the oldest patient is 72 years. So there are situations where even after 60 years, you go for realignment procedure. Correct the deformed bone. If it's a varus, if it's a knock knee, a bow leg, usually it is the tibia that is the culprit. And if it's a knock knee, it's usually the femur that is the culprit. So find out which bone is deformed and correct that particular bone. There is no hard and fast rule like varus, you correct tibia, or valgus, you correct femur. So I prefer to do a fixator assisted high tibial osteotomy because I am trained in that. You can do it with a plate also. Why I prefer fixator? Because it's by gradual correction that I do the final correction, and it gives me an opportunity to fine tune the correction. So this is the full length X-ray which is taken prior to getting the patient to the operation room. You calculate these angles and it is it's purely mathematics, correct these angles. So operative steps, you put an external fixator just 2 pins above, 2 pins below, and through a 1.5 centimeter incision, you cut the bone, and you've cut the bone only 50%, not full. So 1.5 centimeter incision, low energy osteotomy, just with an osteotome, it takes 15-20 minutes. You allow the patient to walk from day one, touchdown weight bearing. You start distracting that, basically opening up that fracture after 1 week. It takes around 3 to 4 weeks for that alignment to get corrected. Once the alignment is corrected, the patient is free to walk around, but with the fixator. And the fixator retention time is average 3.5, ranging from 3 to 4.5. Now that's how you distract it and correct the bend. Earlier it was a bow leg, now it's getting corrected. And that's the X-ray. You can see that right side, he still has a bow leg, and left side is completely corrected. Now one frequent question is, how do I walk with this fixator? Now it's as simple as that. You are freely able to walk with a fixator, and the most important thing is when you do it with a fixator, after 3.5 months, you remove the fixator as an outpatient procedure. No need for a surgery to remove that. So that's the follow-up at 8 months, and he got his second side also operated. When it is femur, you can go for plates or a fixator. Selected situations, we use a fixator. You can see that here, it's basically a valgus, and the lateral compartment is mainly affected. And this is how it looks after correction. And see that the lateral compartment joint space is reasonably maintained. That is not because immediately the cartilage has regenerated. It's because the axis has shifted to the opposite side. You can do this with a plate. I personally don't prefer, because perfection is always by a fixator. Total knee realignment, that is the TKR of a reconstructive surgeon, where your femur and tibia is involved. This is a 45-year-old lady. She was advised knee replacement from multiple centers, and you can see that the right knee while she is walking is giving way. Right, so that we call it the lateral thrust. Corrected the femur by plate and tibia by the fixator. And that's at 3.5 months. She is fully functional, full range of movement. You can get this much amount of knee range of movement when you do a joint replacement, but it's at the cost of degenerating that replaced knee. So that's her walking prior to the surgery, and this is her walking after surgery. And look at the right knee. That lateral abnormal movement is completely gone. You see these patients in your day-to-day life. So extended indications, a 58-year-old male, predominantly unicompartment symptom, but X-ray wise, he has involvement of multiple compartments. But he was not willing for a replacement. So after explaining the risk that surgery can fail in a particular subset of patients, we took him up for surgery. That's his preoperative movement. This is the follow-up. You can see that this is how he walks prior to surgery. And see that movement. That is because of your abductor muscle weakness. What you call the Trundlenberg gait. And see here, it's comparatively getting better. He needs a little bit more of a muscle strengthening, but definitely he is better. And see the range of movement. So in selected patients, it's a very beautiful surgery which gives excellent results. So why I use a fixator? Only because my perfection is better with this. Replacement, I'm not against replacement. I'm always for replacement, but in selected patients. It's an excellent option in elderly when you have a tricompartmental disease, when the entire knee is damaged. We do at our hospital, myself and my teammate is actually a replacement surgeon. We teamed up around 14-15 years back. We do a reasonably good number of replacements also, but only when it is absolutely indicated. Issues happen when you extend the indications when you do a total knee replacement. So what ultimately you get is a painless, stable knee with less complications, immediate symptomatic relief. These are the advantages of getting a knee replaced. But tricompartmental osteoarthritis, I will still tell you, this is the best treatment option available when the knee is completely damaged. So that's a total knee replacement. And this is just like, it's only now that we have chopped down all the trees that we can see the damage that we have done. Replacement has been in vogue for past 10-15 years, and now we are going to see the complications. We have already started seeing. Again, I tell you, I'm not against replacement, but do it when it is absolutely indicated. That's after a knee replacement. She is walking. She came to wheelchair on day 1 to our hospital, and now she is walking freely. It's 1 year post surgery. This lady had a deformity on both her knees. One side was severe, so we said no option of realignment, we'll go for replacement, but first we will do the realignment on the relatively normal knee. She got her HTO done, that is the realignment procedure, 11 years back, and 8 years back she got her knee replaced. Now she met a couple of months back. This is what she told, my right knee is good, but my left knee is better. The realigned knee is definitely better than the replaced knee. So the take home message is conserve in early stages, realign when it is unicompartmental, when it's an alignment problem and there is a failed conservative treatment. It's more of a preventive surgery. You are preventing either a future knee replacement, or if at all required, you are postponing it till the age of 60-65 years, and replace when indicated and try to postpone as much as possible. Thank you. This is our ortho team at Athraya Hospital.
Thank you, Dr. Krishna Kumar. And I'm sure we have many doubts regarding this to clear, but we'll postpone the discussion time till the next session. I now invite Dr. Ram Kumar Menon to discuss neurosurgery, where we stand today.
Direct screen sharing. There is something.
Either presentation, minimize you. Copy nalla. Copy nalla. Good evening. At the onset, let me first thank all the office bearers and the senior members of the IMA for having given me this opportunity and us the opportunity at Athraya Hospital to participate in this meeting. I stand here. Right. I stand here with two intentions. One is to actually to get the message to the members here as to what we do here. It's just that the hospital is new. It's just about a year and a half, 18 months old. But the work that we have been doing has been on for quite some time, just as KK said. And interestingly, I think we share the similar surgical concept. So we work for normal tissue preservation. And my first part of the talk would be on neurosurgery. My second part of the talk would be about the hospital, where I would like to introduce to the members here as to what we do in the hospital. We commenced our operations in September 20. And with over full-time and part-time doctors, we are about 52 plus. So let me go through the small academic part of it first, which is the neurosurgery part of it. Again, the team is quite comprehensive. It has a full team of neurologists, neurosurgeon, psychiatrist, clinical psychologists. It's a complete neuro team. When I named it like neurosurgery where we stand today, it's clearly with one intention. Neurosurgery where we stand today as to what we do in the hospital and how we compare ourselves to the state of art neurosurgery that is being performed worldwide today. I've just segmented into the basic portions of neurosurgery that we encounter. So I've divided into kind of neuro-oncology, neurotrauma, cerebrovascular, pediatric neurosurgery, peripheral neurosurgery, spine surgery, and functional neurosurgery. And for each, I'll give you an index case. I'll show you an index case for each of these. So let me start with the cerebrovascular. This is, I mean, there are of course a lot of aneurysms, a lot of arteries inside the brain, circular villus. Just one of these patients who has presented with the, if you look at the eye, there's a left-sided lateral deviation, and the patient had an ophthalmoplegia, evaluated. I mean, this is in another CT of not this patient, but this is what the classical finding is. You will find a subarachnoid hemorrhage. This is just to show you the circular villus. The most common diagnostic modality as soon as we get is a CT angio, identify the aneurysm. So CT angio is way better than an MR angio, and digital subtraction angiography is way better than a CT angio. But CT angio is the most commonest modality that is available all over. And we have a 32 slice and we are able to pick up aneurysms pretty well. So if you look at this, you can see that on the left side, you can see a globular lesion, and that lesion there, that's actually the aneurysm that was causing the ophthalmoplegia. This is just another picture, another 3D picture where you could see the basilar artery aneurysm. You can see that the basilar artery is there, and you could see the aneurysm there. So just to show you, the same patient, you could see that there is a basilar artery aneurysm and a simultaneous middle cerebral artery aneurysm on that end. I mean, these are some of the measurements that we take in before we go ahead and operate the patients. We would clearly strategize patients in today's scenario as to what needs to go in for surgery or what needs to go in for an endovascular. This is just a post-op image of these patients, how we approach this. These are all like neurosurgical terms, which I am not discussing here, and post-op image of the patient. Some of these patients. So as I said, every index case I'll show you, I mean, I'll just go through a video. This is a classical surgical approach for a standard approach for all surgical procedures, especially a frontal, what we call the anterior circulation aneurysms. But this particular approach, what I'm showing you is an approach which we do, which I've done for a basilar top aneurysm. And just before I walked into the stage, Joy Manila sir told me, well, neurosurgery has a very poor prognosis. It's a specialty which has got a very poor prognosis. So I think I would like to change that mindset to make you really understand that we salvage patients to near normal. So that's the optic nerve that you see there. We're just opening up the cistern, clearing up the CSF space. Microneurosurgery today is pretty advanced. With the kind of imaging that we have and kind of accessories that we have, a safe surgery is something that we can really go about. So we're just trying to open up the cisternal space. And if you see that I'm opening up the sylvian cistern, and then what you see, the spiderweb things are the arachnoid membranes. And then you just open up the arachnoid membrane. And you could actually go right from the front to the back. That is, you could go right from the anterior portion to right up to the basilar artery, which is in the posterior part of your brain. So you dissect the arachnoid around the optic nerve. What you see there, this is the optic nerve, the carotid artery, and this is the optic nerve, and this is the opticocarotid cistern. So basically, this is the carotid artery on the left. This is the optic nerve. We are working on the opticocarotid space, which is called the opticocarotid triangle. And that is a triangular corridor that we access right up to the basilar artery. So you could work around the space, access all the aneurysms around the anterior cerebral artery, middle cerebral artery, ophthalmic segment artery, carotid segment artery. So now as we dissect the arachnoid, we reach posteriorly. So this space where I'm dissecting right now is actually the interoptic space. This is the opticocarotid space. And so as soon as we dissect into this and the depth, you open the what we call the Lilliquist membrane, you could see the top of the aneurysm there. So I'll just take it a little forward. So we are opening up the liqueous membrane, and we could visualize the basilar artery there. Let me just take it a little forward. So that is the top of the basilar artery. What you see close to the retractor on this side is the aneurysm. So we have our estimates of what kind of clip, what kind of dimension. I mean, just as an typical surgery or a surgeon does for all kinds of surgery. So what we see clearly is the neck. Now what I've done is actually taken the clip, tries to assess the width of the neck. Yeah, and then just clip the aneurysm there. What you see is the clipping of the aneurysm. So once the aneurysm is actually clipped, if we need to assess the distal end of the clip, we can take in an endoscope and look at the distal end of the clip, and completion of the procedure. So let me just skip and now go to the, okay. So that's a curved clip. Sometimes we put a temporary clip wherein we want to take a control of the vessel before it, but what we call a proximal control just in case the aneurysm ruptures. So if you see, I've tried two different types of clips. One is a curved clip and the other one is a straight clip. Because when we clip the aneurysm, we want to ensure that the distal end is not clipped. You don't entrap a normal artery there. That is the reddish thing is the cherry thing is the aneurysm, and this one. So this has been possible. All this kind of surgery has been just possible because of the kind of magnification that is available right now. So currently we have the instrument, what we call we could assess the intra-op patency of any vessel. I'm not just talking of neurosurgery. I mean neurosurgical arteries or vessels. We could assess the patency of anybody. If the plastic surgeon was using the microscope, he could assess the patency of the vessel by using what we call an ICG. I'll come to that. So this is this is an index case of a trauma. So what you see here is a kid who had what we call a transorbital penetrating head injury. You can see the black eye. And if you look at this MRI, you could see a white line that is going along this brainstem. It's actually a papadakolu which went right through the eye, right up to the brainstem, and child came to us on a ventilator. We managed him conservatively. He did very well. He went home. So that has been possible because of the team, the critical care team, the intensivists, the team of doctors, the resident doctors, the nurses who were responsible for taking care of the kid. I mean, I didn't do anything for the kid. I just observed the kid and managed him conservatively. The people who were taking care of the patient were all these people who were actually involved. I think that the absolute credit goes to these kind of people. What you see here is a subdural. Very interesting case of a pneumocephalus. The guy had an injury somewhere in October, somewhere in Perindalmanna. He just developed weakness from January. And then I did a CT and we found this huge pneumocephalus. So it's a pneumocephalus causing weakness, contralateral weakness. So where was the problem? The problem was right here. You can see the breach in the inner table. Took him up for surgery, sealed the area. He did very well. He's actually an engineer. He fell down from the bridge while he was constructing the Edapal's flyover. So I think all this has been possible because of the team that works at the hospital, and I'm extremely grateful to the team that works in the hospital. I must say that it's an excellent set of people who work there, right from every single person. They take care of the patients beautifully. So this is our ICU and critical care, and as I said, I'll keep introducing the hospital in between my talk. We have a 22-bedded critical care unit, and we see our patients. So let me just come to the next one, which is neuro-oncology. So we see a variety of neuro-onc patients. What you see on the left side, that one is actually a 11-year-old kid, 16-year-old kid who actually came with visual disturbance. It was a intracellular craniopharyngioma. We did a combined approach. I took help from my ENT surgeon, and we did a combined approach. The whole thing was decompressed, and the child did very well. The vision is not fully recovered yet because it's just about 6 months. The vision is recovering. But let me tell you, what do we do different here? Or I would say, what are we trying to do with this hospital here? What is so different? So look at this. If you look at that image, that is actually, you see a brain tumor. That's a glioma. And you can see the yellow stain. You can see this yellow stain below. That is my OR. That is the yellow fluorescence. So today, when we operate these brain tumors, we do what we call yellow fluorescence, yellow 560. We inject yellow 560. We delineate the tumor. We go about with very aggressive resection of these tumors. And during the resection of these tumors, the yellow area is for us for sure that the normal brain is not involved. So we are able to resect gliomas with much higher precision, much higher accuracy, and we are able to adhere to the principle of maximum tumor resection with safety, even in eloquent areas, which are functional areas. So we could operate these patients, preserve them as much as we could. This lady came in with a hand drop, a wrist drop. We did the yellow staining, and we resected this tumor. It turned out to be a GBM grade 4. Subsequently went on for radiotherapy. So what is so different? Again, what is so different that we are able to do here? So if you look at it, we do what we call MR spectroscopy on this image here, and we do what we call MR perfusion here. So what does this help? The spectroscopy is what we call a chemical imaging. It helps us to identify that this is a tumor, and the perfusion on the right side tells us the vascularity of the tumor. So when we go in when we go in for the surgery, we are prepared. It's like going for a war, you go fully prepared. So how does the perfusion help again? When you have achieved a resection, during a post-op scan, you again do a perfusion, see what is happening to the vascularity of the tumor around. Or if the patient has come back to you after a radiation, do a perfusion again. It will help you to tell you if there is a radiation necrosis or if there is a recurrence of the tumor. So today, the technology is so advanced. Why I again tell you is we named it as what we do is what is currently available as best in the world today in terms of the add-on services, in terms of the technology that is available. This was just an acromegaly patient. He did very well. We had his levels, growth hormone levels, which fell down substantially. Again, neuro-oncology, this is just an optic nerve glioma. This was a kid I had operated a few years back. The kid is today a professional dancer. At that point of time, I did not have the yellow 560 imaging. So it went on to be more like a biopsy followed by a radiotherapy. But today, if this patient was to come to me, I would do a yellow 560 staining. So this is from the pediatric neurosurgery. This was one of the recent cases that I operated. This was a caudal regression syndrome in a kid who had bilateral foot weakness. If you look at this image, you could see the MRI on the right side. You could see the hydromyelia, the syringohydromyelia, and you could see the absence of the sacrum distal to the S2. And you could see the tethering there. So what could we offer this kid? So that is the microscopic image. You could see the two cords with a single dura. So it was a diastometamyelia way up, and you can see the two. What we are trying to do here is detether. On the left corner where my pen field is working is actually the lipoma, which is causing the lateral tethering, and there is a distal tethering right. Both the cords, there were two cords, and both were tethered there. So we use what we call intraoperative neuromonitoring for these cases. So that is the lipoma. and you have the two cords there. And here what I'm trying to do is detether the cord. So how do we take a decision to detether the cord? That is by an intraoperative stimulation. So there were two cords. What we did was we stimulated the end, ensured that nothing is getting stimulated. So when we detethered the right one, there was no stimulation. We could detether it very well. When we detethered the left one, the sphincter was getting stimulated. So we didn't detether the other one. The child did very well, had urinary retention for a couple of weeks. She was on catheter. She came out very well. So this is detethering. These are all just technology that helps you, that guides you, and helps you perform a safe surgery. It's not about getting an MR image of 100% excision. It's all about the safety of the patient, achieving safe surgery. So all these nerves were stimulated intraoperatively to find out whether that was stimulating any vital or any critical organ. And there is a constant monitoring happening in the lower limbs. She's probably, I think 4 or 5 years, 4 or 5 year old, and she's doing fine. I think as far as surgeons are concerned, it's all about performing safe surgery. And for safe surgery, have all the armamentarium for a safe surgery that probably helps you to perform the surgery safer, and the most importantly, helps you keep away from litigation. Just in case there's somebody pulls you down for a litigation, at least you know you have these things at your end, and this is the best that is available in the world, and this is what you're doing with. So that will take care of the litigation part of it also. So this is the kid after the surgery. She just followed up in the OPD. She's doing fine. She's running. So if I were to operate this kid without a intraoperative stimulator, and if I had detethered the left side of the cord, she would have been lifelong a bladder issue. Again, a hospital that we are pretty young. The force is young. The energy is high. The vibes are high. This was the celebration of the completion of the first year. This was in association with the IMA blood bank, where there was a blood donation. We are happy and we're proud to say that we were able to donate probably 42 bags. Yes. And so we celebrate the recovery of some of our patients, some of our festivals. This was the NABH accreditation that we got at the pre-accreditation, I would say, that we got at 7th month after the hospital opened up. And I think we are very proud of that. What you see here is a patient right in the center. You can see this lady. She stayed with us for about 45 days, COVID, severe complications, on the ventilator for about 28 days. The team did a fantastic job. She recovered very well, absolutely beautifully. I think hats off to the team. They're all here. Dr. Sachin is here, Dr. Varghese, Linesh, everybody is here. So this is one of the peripheral nerve tumors that I said that we would do, that I had done. It was a large tibial nerve neuronoma, again with intense pain. So what you see here, right, is what I was talking about, is using intraoperative neuromonitoring. So you see those areas that you specifically want to stimulate and monitor and see. Resected it pretty well. This is our OT. We have 5 operating rooms, 3 in the supramajor in the top floor and 2 below, where I would say we are reasonably well equipped with most of the things today to perform safe surgery. And I must proudly say that we did complete over 1,000. Neuro-oncology. So this is what I was telling you about the stain. So what you see here is this particular tumor there. And the anesthesia team is fantastic, because we don't even look into what is being done. You know, you just tell them, okay, we need the dye in, and the dye is in. So if you look at it, there was a blue filter. The blue filter goes in and the dye is injected. That you can see the vessels taking the stain. Then you want to look at the resection again, come back to the regular view. You resect the tumor, Keep checking with your yellow fluorescein stain. You can see the tumor taking the stain. You go ahead and resect the tumor as much as you can. And that would be as safely. Rather, it's not about as much as you can, it's about as safely as you can. When we started off using this particular technology, we were the only institute in Kerala to use this technology. Currently, a couple of months back, Amrita also installed the same. So this was the resection of the tumor. That is a tumor bed. So we can actually, when based on the infiltration, we could actually find out how much of the normal tissue is getting infiltrated. So after the resection, the tumor bed appears apparently clean. And we resected the tumor well. So coming to the next one, which is probably spine. We see a lot of spine patients, something which actually I love to do. It's a micro anterior cervical discectomy. A patient, of course, had come with a neck pain and a weakness in the hand. So when we work with the magnification, this kind of a magnification where you can actually see, in fact, everything. You can see the PLL, posterior longitudinal ligament. You could see the dura. You could see if there is any laceration on the dura. I think your surgery becomes very, very, very safe. We even instrument with the microscope on, especially up to 2 to 3 levels, we are able to instrument it with the microscope. So even your screw placement is under guidance, and then we check the screw positioning on the C-arm. So once you have completed it, it's just about assessing the size of the spacer, getting your right interbody spacer in. These are incisions which are actually reasonably small. I don't say they're micro, they're reasonably small. They're about 3 to 4 centimeter for single level. And patient is functionally very good. They can usually get back home in a couple of days' time. If we were to take a graft from the hip, yes, they would stay for a couple of days more longer. Otherwise, they just go home very fast. So I was telling Joyce that neurosurgery is not what it used to be or what people think about it. We have been trying to bring in some changes, and especially with so much of technical advances, I think the results are excellent. So that's all. You could see the dura there very well. You could see the upper vertebra, the lower vertebra. Ensure that nothing is there left behind. You check it with your pen field. No fragments. You introduce the spacer there. We introduce the spacer. And then we go ahead and just plate it. You size it, you confirm it, you put the plate, screw them. And patient is actually, after surgery, ready to go home in a couple of days' time. I'll just briefly run you. These are all 7 millimeter incisions, very small incisions for lumbar discs. Functionally intact, no bone is taken off. We just work through the ligament. All this has been just possible because of the kind of magnification, the kind of equipments, and the kind of support that we get, and the kind of monitoring that we use during the surgery. Basically, there is no bone taken off. We work on the flavum. You basically incise the flavum, get onto the spinal cord, retract the spinal cord, get into the retrospinal space. So you could see how the flavum is removed. No bone is removed. Where we can, so it's all about preserving the anatomy, doing the minimum and preserving the function. So this is all a part of what we call functional neurosurgery. We could get these patients back home in a day's time. That was a fragment, yeah. The incision is small. The recovery time is very fast. This is just to show you what is happening with the post-op, where you have a spinal tumor excision. Again, MIS, minimal invasive spinal tumor excision. This image will show you that the left side of the lamina is fully preserved, and only the part of the right side of the lamina is taken. This is the incision. This is again about 2 centimeters. It was a conus cauda neurofibroma, which we resected. It was a lady with a thoracic neurofibroma. The neurorehabilitation team, again, very strong. We treat all these patients of quadriplegia, with respiratory arrest, with paraplegia. The rehab team works really hard for this. This was one of the patients who had a paraplegia, and we had instrumented him. Our aim is to mobilize him as soon as possible. He's an accountant. So what do we do for this? We just put him on a prosthesis, and then we put him onto what we called a functional prosthesis, where he could walk alone without anything. So this is just to show you what we do with the pain management. The spectrum of neurosurgery is what I've showed here. A microvascular decompression for trigeminal neuralgia. Let me just, what you see is the trigeminal nerve. Again here, what you see in trigeminal neuralgia is basically an artery or a vein that is compressing the nerve. And how do we identify the artery and the vein if you're not able to see? You do an ICG dye. You do in the microscope, you put an ICG dye, and you could, the indocyanine green could show you the vessel which you're not able to see, and you just need to separate it. So this is what we do. We put a Teflon patch and separate it from the trigeminal nerve. So what is more interesting here is how technology helps you with some of these difficult cases. You see the Teflon patch that is actually going between the artery and the nerve there, the trigeminal nerve there. So in this again, the role of intraoperative monitoring. So if you see that probe there. So that probe is actually, this was a patient who had a trigeminal neuralgia surgery before. It was difficult for me to identify. We used the probe, stimulated it, and then we identified that that was the trigeminal nerve. So you see the 7th-8th complex, which is next to it. Again, stimulate it, ensure that there's a 7th-8th complex, and then go ahead and do the neurectomy. She had intractable pain. She had a previous microvascular decompression surgery. She was on carbamazepine for more than 1,800 milligrams a day. So that was stimulating the facial nerve to see that the facial nerve, that is the facial nerve, and you don't accidentally injure the facial nerve. We were able to do some of these cases for COVID and with some reasonably good results. Getting involved in research or getting involved in some of these things is our dream. Currently, we are too young for getting into that, basically because of the constraints and resources. So we do some of this customization for 3D cranioplasty, what you see here, for different kind. We want to attempt that for even spine, where we are able to remove the whole bone and replace it with the 3D bone. So we're in the process. What you see here, right side, is a navigated surgery for these. This is a 6 millimeter cavernoma causing seizure. And this, if you see these markers here, you can see these are markers. They are optical trackers. So it's a freehand surgery, unlike a stereotactic guided surgery where you have bulky frames. It's a freehand surgery. You go ahead, resect the tumor, and come out. So that was a part of the neurosurgery that I wanted to really go through the first. Something that was more in the back of my mind was to make you understand that about the hospital and what we do. So we want to really contribute to the medical fraternity here, where we want, I can say that every single person in the hospital is going to do the best in their corresponding areas. This is how the hospital looks like. So we have some of these interesting clinics that are running through. This is what you see is the dementia clinic and assistive technology clinic. Dementia clinic basically runs on Wednesday, assesses people with dementia, where there's a dedicated team that actually does the scoring, assesses them. So what makes it so different about it? There's a special study. We call it brain volumetry, where you assess the volume of the brain, assess the shrinkage of the brain. You can objectively identify that, okay, this is your atrophy of the hippocampus, this is your atrophy of cortical area. It runs on Wednesdays. Then we have this vertigo clinic. It's just started off. I think it's still in its infancy. The audiology, the stroke rehabilitation. This is one of its kind device which is available in Thrissur, which is actually a unweighing system which is used for rehabilitating paraplegic patients and spine injury patients. The child guidance and the pediatric neurodevelopmental clinic, where the pediatrician and the psychiatrist, they are all involved in it. It runs on specific days like a Wednesday and a Saturday, and they take care of these kids with autism. They take care of these kids with addiction, especially with mobile addiction. The laser and cosmetology clinic in the hospital basically does all this cosmetic procedures, very advanced prime lace. The TMJ clinic, of course, it's run by our dentist. They take care of these TMJ patients. And interestingly, that was something which we never focused on. A lot of our patients, which I never focused on. And then when they come back to you after they have recovered from a craniotomy where your temporalis muscle is taken out, and then they start complaining about pain in the TM joint, you don't want these patients to talk to you for a long time because your surgical part is over. You send them across, and then you see some excellent results from these dentists. Spine clinic, this I already mentioned. It's as KK mentioned, it's not about doing a replacement for everybody. It's about prioritizing the surgery, individualizing the surgery for these patients. It could be an implant, it could be a spacer, it could be a rod, it could be a screw, but it's basically about individualizing the procedure that we are going to do for these patients. The headache clinic runs. Of course, the reconstructive orthopedics and Elizarov clinic, you heard about them. The wound care. These are some of the departments that are currently running. And these are some of the services that are coming through. So we're going to be having a 24-hour dialysis that is coming through. And when we started off, we never dreamt of getting a maternity child health, but now I think probably we need them. A lot of health checkups that we do, services. MRI, what was the state of that? 1.5P. The lab is doing fine. This is our rehabilitation space. This I showed you. There's a ER space. Some of our IP rooms, OP rooms. Yes, it's not all about being a private hospital and running private services for the hospital. I think we have a vision where we would really like to participate, have some social commitment, take part in activities, get involved in some CSR activities. So if you see, then during the vaccination, we were on the forefront. We were able to vaccinate a substantial number of people. We conducted a camp in association with Vivekananda Mission Hospital at Attapadi. It was fantastic. All of us saw some nice patients, and it was a charitable service. We were really happy about it. Then again, getting associated with some of these, organizations like the police and the volunteer force, fire force, educate them. The COVID vaccination drive, right here. So this is. We would actually like to invite the IMA, and we would like to partner with IMA for this walkathon that is happening on the 22nd on the occasion of the World No Tobacco Day. I haven't spoken to any of the office bearers yet, but I would really request them to look into it, and we would be happy to have you on board. That's happening on the 29th. That's a Sunday in the morning at about 6 o'clock. Please do join us. Please share it with your friends. And this is what we stand for: the health, compassion, innovation, and strategy. And thank you for the patient hearing.
Thank you, Dr. Ramkumar. And now it's discussion time. Can we have both speakers on stage so that we can clarify a few doubts, please? ആർക്കെങ്കിലും എന്തെങ്കിലും ഡൗട്ട്സ് ക്ലിയർ ചെയ്യാനുണ്ടെങ്കിൽ രണ്ട് സ്പീക്കേഴ്സും ഉണ്ട് സ്റ്റേജില്. ഓക്കെ, ചാറ്റിൽ എന്തെങ്കിലും ഉണ്ടോ? ഒന്നുമില്ല. ഓക്കെ, എനിക്കൊരു സംശയമുണ്ട്. അതായത് ഐ മീൻ ഈസ് റണ്ണിങ് ഗുഡ് ഫോർ ദ നീസ്?
What type of running?
Maybe jogging.
Running on a treadmill is not good.
It's not good.
Running on the road is fine.
What difference does it make? I mean,
Now, if you are using a treadmill inside a gym, household treadmills, they are very narrow. So it's just putting strain on your knee. If it's in the gym, if you have a broader one, that's fine.
broader.
Like the basic principle while you run is, you don't give a strain which is directed medially. You run like this.
Like this.
Yeah,
Okay.
like what you do is you give a tilt to your knee when you run. You tilt your knee towards the inner side. So that strengthens your lateral muscles, which is very, very important in terms of the health of the knee is concerned. So for that, you need a little bit of space.
Okay.
So running is okay, but not on those narrow treadmills.
Oh, right. And what about walking? It is good
Walking
for
is
the knees. Fine. And what about climbing the stairs? I mean, there are stair
So
climbers.
if you are
now,
suppose,
etc.
if you are having a situation where you have to limit your activities, the treatment has to be stepped up. At say, before say 65, 70, you can't restrict somebody to climb stairs or to walk brisk. That's the basic thing that we need. So before 70, if you are getting these symptoms, it's time to get your x-rays done and see what is the status.
I mean, if someone has a, I mean, in the mid 50s or so, I am meaning about me only. Is it okay to climb the stairs? Will that strengthen the knee?
It alone does
Climbing the
not
stairs?
strengthen your knee.
It does
For
not.
knee strengthening, you have to do specific exercises.
What about squats and all?
Squats is fine, but that again increases the load on your knee. So what you need is static exercises. What you do
Static.
while doing a squat is a dynamic exercise.
Yeah.
So what you need is a static exercise to
Just
strengthen
like
your quadriceps.
knee,
No, just put a roll underneath
Yeah.
your knee and just press it.
Okay.
That is fine.
Right. Okay. Any more doubts? Okay.
Madam, can you hear me? Hello.
Now it's with great respect that I invite Dr. T.P. Anthony, Professor of Medicine,